for joining me for this presentation. We're going to go over the new changes to acute coronary syndrome and Stemi. Part of this presentation will also be to review the new layouts for the care maps and the medication profiles. If you've been looking at the recent changes in the care maps on the Shared Health website, we've changed the format on how we're presenting the care maps and how we're presenting the medications. So this will be a bit of a review for that as well. Like I said, if you have questions anytime, feel free to throw it in the chat or just put up your hand and we can discuss it. So this is the actual Stemi bypass protocol. It's a lot of stuff, but as you can see, it's got the new layout there. We have gotten rid of the color boxes. They are no longer a thing. They don't exist anymore. The reason we got rid of that was we were trying to streamline the care maps, and when scope changes, we don't have to keep going back and changing 20 different boxes. As I'm sure everybody's aware of right now, it's causing a bit of chaos with changes, so we're trying to streamline it. It's a lot of stuff to go over, so I'm not going to make you stare at this little screen all day. So I'm going to break down the care map into actual step-by-step process for STEMI bypass. So the first box, when you look at a care map, it'll have your scope of work. So with this here, I'm just going to hit that. So the first thing I'll talk about is scope of work. So again, we got rid of the colored boxes. It'll just show who can do what. So for here, paramedics at all provider levels can use this care map for management of ACS or STEMI. But when it comes to scope of work, providers with EMR scope of work cannot carry out the STEMI bypass. So EMRs are allowed to access this for guidance for care, but when it comes to actually contacting the cardiologists, they are not allowed to do that at this time. So reasons we would use this care map is if we have a patient with chest discomfort, pain, pressure, heaviness, other symptoms consistent with or suspicious for acute coronary syndrome. So long story short, basically, if your patient is presenting with cardiac symptoms, we want to access this care map here. The big thing you have to remember, though, as well, is that a lot of the standard presentations for patients with heart attacks is based on like really 50-year-old white guys. That's what heart and stroke originally started as. So all the standard symptoms we look at for ACS, the left-sided chest pain, heaviness in the chest, numbness of the arm, shoulder, jaw, things like that. With that, that is more of a male presentation. We have to be more suspicious with our female patients because they're the ones that get the referred pains, or what we reference to usually. But that's when we talk about things like back pain, jaw pain, shoulder pain. Those are more female presentations. So fatigue is another one that gets kind of put to the wayside. So we need to make sure we're looking at full spectrum of different symptoms for different patient demographics when it comes to this. So other things as well, so indication for code STEMI bypass, known or suspected ST elevation, myocardial infarction, so it's STEMI. We'll break down that in a minute. If the patient can arrive at St. Boniface Hospital cath lab within 100 minutes from contact with EMS. So the big thing to remember with this care map versus the stroke bypass protocol is with stroke bypass, it's when symptoms start. For the STEMI bypass, it's for when we arrive at the door. So it's 100 minutes from when we get to scene. So they could have been having pain for the last 2 days. If they just got tired of it and called us now, that's when the clock starts ticking. It's not when it started 2 days ago. So that's a big thing to keep in mind when it comes to looking at your timelines. And obviously, no contraindications bypassing close to emergency department. So if your patient's about to code on you, go to the closest EDs, try and stabilize your patient first. So contraindications to using this, the code STEMI bypass. So decreased level of consciousness. Obviously, if your patient's obtunded, they can't answer questions appropriately, you can't do a complete assessment, we're just going to deal with that and go to the closest ED. If there's suspected respiratory failure, shock, or sepsis, we're going to deal with that and go closest ED. So known or suspected current internal bleeding, excluding menstruation. So obviously a lot of the care we're going to give for our patients with ACS is going to deal with clotting factors. So if they've got an uncontrolled internal bleed, a lot of the things we're going to do to help these patients can be ruled out. So we're going to have to deal with that first. Known or suspected aortic dissection. So patients with aortic dissection, they may have a history of having that aneurysm already. So, but when it ruptures, you might get sudden intense pain. Whereas patients with ACS may come on slowly, or it may be very exercise related, and it doesn't go away with rest. That's another thing there. So, but the patients that are having aortic dissections are going to have intense, sudden, persistent chest or back pain, shortness of breath. Their blood pressure is going to drop. They may complain of weakness, paralysis on one side of the body, may have difficulty speaking, or basically symptoms of stroke. I had one patient that actually had aortic arch aneurysm, and he was 29 and had all the symptoms of an MI and all the symptoms of a stroke. So we treated it as a stroke, and we went stroke bypass, and it turned out it was aortic arch aneurysm. So that's why we want to deal with that appropriately. So recent significant head trauma, that's going to take them out of using this bypass. That's going to be a higher priority. And advanced healthcare directive saying comfort care only. So again, with palliative care, we always say comfort care does not mean no care. We're still going to care for these patients. We can still give them pain control. We can still take them to the closest facility if that's their wishes. It just, we won't activate STEMI bypass. If a patient has an active DNR, they don't go to the cath lab. We had one patient that we actually got ROSC on. She was symptomatic bradycardic heart attack. So we called the online physician and we treated with atropine and went to St. Boniface, and they had her, she actually signed a waiver to her DNR. So they took her to the cath lab. So, but if they have a DNR, cath lab won't take them. So when it comes to the actual care map here, so first box is we have acquired ECG within 10 minutes of arrival. So we have to remember that with that 10 minutes of arrival, we want to get an ECG as soon as possible. Because like I said before, the clock starts ticking as soon as we walk through the door. So the 100 minutes, we arrive on scene. So we got to get the ECG as soon as possible, because when we look at timelines to get to St. Boniface Hospital, we want to get there as soon as we can. We want to look at giving ASA. We want to look at giving nitro and or a nitro patch. And we can look at giving an opiate analgesic. So the big thing is when it comes to using nitrates, and we all remember this from PCP school, that if they have low blood pressure, we have to be careful with use of nitrates. And we'll go more into the medications in a second. Also, if the ischemic chest discomfort is not relieved after 3 sprays of nitro, consider fentanyl or morphine for further pain management. Note that opiates may cause hypotension. So we really have to be careful about dropping our patient's blood pressure. So what we might want to do is start an IV line before we start giving meds. So that can be concurrent activity. We can be doing our 12 lead, doing a set of vitals, getting an IV ready to go. And a big thing is when you notice here in the care map, we used to have the medications would be color coded. We don't do that anymore. So how it works now to reference medications is that if the care map says administer a med, you will then use that prompt to go to your medication profile. Your medication profile will go over your scope, who can do what at what level, and that is what you're supposed to use to decide if you can administer medication. We're trying to pull the meds out of care maps. So we're just going to put prompts for you to go to the medication profile. So if you're reading your care map and it says give medication, you go to that medication profile and it meets all the requirements, then you're authorized to give your medications. So that's how we're doing it now, not just with color boxes. So ASA, we've been given this for a long time. It inhibits platelet aggregation by interfering with the production of thromboxane A2. So there's your trivia for the day. It's a substance that stimulates platelet aggregation. So giving ASA pre-hospitally makes a huge difference, because if there is clotting forming, blocking the blood vessels, that'll slow it down. So for this one here, so this is the actual medication profile as you would find in the Shared Health website. So you can see color boxes are gone. It just has the title, your medication summary, and then you just list the scope of work of who can give what. So with this one here, this document constitutes a standing order that allows paramedics to administer medication. So again, care map guides you ASA, you go to your medication profile, it states here's your guidance. If you match up, then you can give this medication. So this medication here, providers at all levels may give ASA as outlined in this document. And we would give it obviously if we were worried about ACS in our patients. So contraindications giving this, obviously active bleeding. ASA prevents clotting. If they're bleeding, that's not a good thing. So hold off on the ASA, especially if you're worried about that aneurysm as well. Don't give them ASA. If they're allergic to the drug, that's always a safe question. Safe answer. We're in school with multiple choice. Why don't we give a drug if they're allergic to it? So that's pretty standard. And if they have known ASA-induced asthma, we don't want to start giving them asthma issues to go along with their cardiac problems. So for ASA, it used to be we had 160 to 325. Now it's just straight up 160 and just have them chew it.
Mike.
Yep.
Quick question. How can I make my screen bigger so I can see your presentation?
That's a good question. What can you see right now?
I see a yellow line with something that might start with a D.
Is everybody else seeing that, or is that just Thor? Do you have your text box open or anything?
No.
Okay.
So on the screen, I have a picture of you, a picture of me, and we're on page 7 of 30. I see dosing and oral, but I can't see the medications. I can look if I put my nose right to it.
Okay.
If you hit Control and use your scroll up, it should make the screen bigger.
I tried that. It doesn't. It makes it, wait. Yeah. Okay, I won't stop you. Just keep talking.
Okay. Can everybody else see the slides okay? All right, awesome. Thank you. All right, so giving nitroglycerin. So again, this one we've been using since the dawn of time here. So basically it causes that increase in vasodilation, reducing workload on the heart, and helping get more blood flow to the coronary vessels to help perfuse the heart. So again, with this one on the care map, it's set to consider nitroglycerin. So when you go to your care map and you see nitroglycerin, that would prompt you to refer to your medication profile, and then you would use those two together to confirm that you're allowed to give this medication. So again, this scope of work, again, this is the medication profile on the Shared Health website. So this gives you permission to use this medication. So providers at all levels, so scope of work, all levels may administer sublingual nitroglycerin outlined in this document. So providers with PCP and up may administer topical nitroglycerin only as outlined in this document, so in the medication profile, or with order from an ERS affiliated physician, so your online medical. So providers with ACP scope of work may administer IV nitroglycerin as outlined in this document. So as we're all probably pretty aware right now, we don't have ACP scope of work in this region right now. So everybody is working at max and ICP scope of work until that changes. So indications, so chest pain discomfort, consistent suspicious with MI or pulmonary edema. So we're going to go with the MI aspect for this medication use. So reasons we don't give nitro, if like everything, they're allergic to it, they have a hypersensitivity. Use any of the following from the last 24 hours. So Viagra, Cialis, Levitra. So when it comes to using erectile dysfunction medication, again, that causes vasodilation. We start putting nitrates on top of that. It can cause extreme vasodilation, causing blood pressure to drop. We had one call where it wasn't myself attending, it was with the medical supervisor I was working with in the city at the time. We had a critical incident where EMS crew actually gave female a nitro spray, and they didn't ask her if she was taking any of these medications. So Viagra was originally created for pulmonary hypertension, and then they found it had beneficial side effects, so they decided to market it that way. But this female patient was actually taking Viagra for her pulmonary hypertension. So they didn't bother asking because they figured it's a female in her 30s. Why would she be taking ED medications? And they gave her nitro, and they almost killed her. Luckily they had an IV in place, and they started giving her fluid boluses. So it may seem odd asking someone in their 30s, especially females, if they're on any erectile dysfunction medications, but it does happen. So just something to keep in mind there. So if your patient's already hypotensive, we're not going to give nitro. We're going to stay away from that. If they have increased intracranial pressure, we're going to stay away from nitro, and any established diagnosis. So obviously these are things we're not going to figure out in the house. We're not going to figure out this person has hypertrophic cardiomyopathy by just listening to their heart. So it would be good to get a history from the patient of if they have mitral stenosis, if you suspect pericardial tamponade, constrictive pericarditis, or restrictive cardiomyopathy, hypertrophic cardiomyopathy. You're going to have to talk to your patient, and if you don't know, then do your best. So again, the big one with nitro is use caution if known or suspected right ventricular infarct. And we can do that by doing our 12 leads. So again, that's why it's so important to get our 12 leads done first on these patients. So our dosing for nitro for 17 years and older, it's 0.4 milligrams sublingual, repeat every 5 minutes as required. If we're going to use transdermal, it's straight up just 0.4 milligrams an hour. So when it comes to transdermal patches, whenever I teach ACLS or anything like that, I always like to ask, where do you put your patches? And everybody's got all these different places. For some reason, people like to put it on the people's back, on the shoulder. It's actually recommended guidelines when you use the transdermal patches to put them along the clavicle on the front. It gets absorbed very quickly there, and also that way when you get to the ER, it's very obvious it's there, and if you need to take it off because they become hypotensive, it's very easy to access for us. So that's the recommendations put forward. And again, for intravenous nitro, that's for ACP and up, as per direction by online medical support. So fentanyl. So I talked about giving opioids and opiates for pain control. So we're going to talk about fentanyl first. Fentanyl, I'm going to talk about a bit more when we get to morphine, but fentanyl is preferred for patients with ACS over morphine. So with fentanyl itself, again, here's the medication summary as would be found on the Shared Health website. So for scope here, again, this is your standing order. So basically providers in the EMR scope may not administer fentanyl at all, even with a physician's order. So providers with PCP scope of work may administer IN fentanyl. So we just got the go-ahead to reintroduce intranasal medication administration yesterday. So with that, if you are going to use intranasal, you have to wear all your extended PPE. So wearing all the stuff, the gown, the mask, everything. But at least we have that route for access now again. So PCP and ACP can give fentanyl other routes, but for PCP, it's still just intranasal. So indications for this, so obviously any kind of pain, so exacerbation of chronic condition or something that's acute. So contraindications, like everything else, if they're allergic to it, don't give it to them. If they already have a decreased LOC or significant head injury, if they have significant drug or alcohol intoxication, we don't want to sedate them even more. Uncorrected or uncorrectable hypotension, again, we don't want to bottom out our patients, and hypoventilation or respiratory failure. So intranasal dosing, so again, it says in the general instructions, again, before you give this, you need to put on your extended PPE. It's 2 mics per kilogram, single max dose 100 micrograms. If it's 12 months to 10 years, 2 micrograms per kilogram, single max dose 50 mics. And the big thing is, like it said in the notes there, when you give your intranasal, spread the dose between both nostrils to assist with just absorption of the med. So give half the med through one nostril, half the med through the other nostril. So IM, 10 years and older, 2 mics per kilogram, single dose max 100 micrograms to a max of 200 micrograms per hour. Again, if you're finding fentanyl is working for you, because fentanyl's got a very short half-life, it gets absorbed very quickly, but it goes through the body. It lasts about 20 to 30 minutes. If you're finding you have extended transport time and the fentanyl is working well for your patients, not putting them in any hemodynamic instability, you can always call online medical support to request the permission to go past the maximum. That's fine. It's not going outside your scope. You're just asking to give more medication for therapy. So you can contact online medical support for that. And again, for here, for 12 months to 10 years, we have our 2 mics per kilogram to max 100 micrograms per hour to max of 50 mics per single dose. And you can repeat it every 30 minutes. So if you're going to give it IV, it's 1 microgram per kilogram for 10 and up to single max of 100 micrograms, cumulative max 200 micrograms per hour. And then it's 1 mic per kilogram for 12 months and up. Okay. And again, a big thing here, it says here to make note for IV, it says it's a slow push. Don't just fire it in there. It's about 60 seconds. And you repeat it every 10 minutes as required. It'll work very quickly through IV. So again, just keep an eye on your patient's blood pressure. And like we should with all meds, try to do a set of vitals pre and post medication administration. You can give fentanyl through the IO, but they don't want you starting IOs just to give fentanyl. That's kind of mean, because if anybody's ever seen someone semi-conscious or conscious get a medication through an IO, it hurts. So it's kind of counterproductive to put them through pain to give them pain control. So again, it's less likely than morphine, but fentanyl can cause a drop in blood pressure. So if you're giving IV, great, just monitor their vitals, be ready to give them flu bullets if their blood pressure does drop. And again, we can sedate these patients. So like it says there, if they're elderly, maybe not give them the full dose, give them a bit first, see how it goes, or push it a little bit slower, see what the reaction is. That's fentanyl. So again, fentanyl for ACS is the preferred medication as per heart and stroke guidelines. And it's been like that for quite some time now. But it does suggest giving opiates. So if fentanyl is not an option, I know I've had patients that when fentanyl was killing everybody, we had patients that absolutely refused to take fentanyl. So if that's still a mentality, you could look at giving morphine. But again, fentanyl for ACS is preferred. So for this one, again, your scope of work, we got rid of all the colored boxes. So for morphine, it cannot be given by EMRs or PCPs, even if you have physician's orders. It didn't happen in this region. We just had a shared health meeting, and there was actually a PCP in another region that got physician's orders to give a morphine infusion. So the PCP took the morphine infusion, took the pump, and did an IFT, which is completely outside of scope. But they figured because they had a doctor's orders, it was okay. So that's not allowed. So just keep that in mind. So when it comes to morphine, this is basically for PCPIs or ACPs. So indications. So we want to give, basically it's for pain control, long story short. So contraindications, again, like everything else, if they're allergic to it, decreased LOC, significant head injury, significant drug alcohol intoxication. So basically we're looking at the same things as fentanyl. So if we're going to give it IM, and we're doing a lot more weight-based, it's 0.1 milligrams per kilogram to max dose of single dose of 10 to cumulative max of 20 milligrams per hour. And again, like I said before, if you're finding it's working well for your patient and you need to give more than that because you're looking at extended transport time, you can contact online medical support. Big thing to keep in mind is that the morphine we have in our pouches is made for IM, so we do not want to dilute it if we give it intramuscular. It's just draw and give. So if you're going to give it IV, then we have to remember to dilute it now because the morphine we have is for intramuscular administration, so we want to dilute it. And remember not to mix it into your pre-filled syringes. We need to draw either saline from the bag or from the saline vials we have. So if we're going to get IV, it's 0.1 milligrams per kilogram, max dose 10, max dose of 20 milligrams per hour. So if you're looking for more long-term, morphine does last a lot longer than fentanyl when it comes to half-life. But on the flip side, it's sometimes nice that fentanyl has that shorter half-life because if your patient does have a negative reaction, it's going to be out of their system a lot faster. Morphine will stay for quite some time, like 2 to 3 hours on some patients. So if they have a bad reaction, you're going to be dealing with it for a while. So again, slow push over 60 seconds. So don't just fire it in there. Just make sure you keep an eye on their vital signs as well. You can repeat it every 15 minutes as required. And again, same rules with the IO. So patients who are compensating for hemodynamic compromise might develop hypotension after morphine administration, just same thing as fentanyl. So the big thing with American Heart Association and Heart and Stroke in Canada is that they found morphine is actually quite detrimental on patients that are having ACS. So it has the vasodilatory properties, but they found it more so than fentanyl. And so it decreased venous tone, which reduced blood pressure, causing a lot of issues. The other thing as well is morphine affects gastric motility. So if they've swallowed oral anticoagulants that is directed by the cardiac physician, it may actually not get absorbed because they're basically morphine is going to slow down all their gastric motility. Also, a study done in 2017 showed that morphine increased the 30-day mortality when used in acute heart failure patients in the emergency department. So they found patients that were given morphine for ACS and the ED had a higher risk of death, long story short. And it actually was shown in one study taken about 15 years ago that it actually increased infarct site in the heart. So it actually made their heart attacks worse. So that's why current guidelines, the recommendation is to use fentanyl for patients with ACS as opposed to morphine. So it's all fun talking about meds there. So we're going to get back to the care map here. So we're going to do our 12 lead. And does the ECG indicate a potential Stemi? If the answer is no, we go to the closest ED. So when it comes to looking at your 12 lead, if you're ICP, you can actually print it out, take a look at it, make your own decision. For PCP, you can just read what the printout states. So paramedics consider an STEMI if the monitor defibrillator automated interpretation indicates a STEMI or suspected STEMI. For the all X-rays of prompt, STEMI will appear. So last year I found when I put out reading material about if it says STEMI, you call the STEMI physician. I had a lot of paramedics that weren't calling the STEMI physician because it didn't say STEMI. So just as a side note, if it says anything that uses any of the words in STEMI, so myocardial infarction, elevated ST elevation, so you want to call the cardiologist. We'll get a little bit more in depth with that. So if it says suspected right-sided infarct, that's the I in STEMI. Contact the physician. It doesn't just have to be that STEMI word. Anytime there's infarct, suspected MI, all that stuff, we want to consider, are we going to call the cardiologist, not just those 4 letters flashing on your monitor. So if you are able to interpret your ECG, we want to contact the cardiologist if the ST segment elevation at the J point of at least 1 millimeter in any 2 or more contiguous leads. And what that means, it has to be the same anatomical region of the heart. So if you notice in lead 2, there's some ST elevation, and V1, there's some ST elevation, different parts of the heart. So that's not contiguous leads. So if you notice ST elevation leads V1, V2, V3, absolutely, we're going to contact the cardiologist. If you see ST elevation of the J points in leads V2 or V3, at least 2 millimeters in males over age 40, at least 2.5 millimeters in males under age 40, and at least 1.5 millimeters in all adult females. So especially for the PCPs out there, this is why it's really important before we do our 12 lead, we put in our patient gender and our patient age, because based on that, the Zoll is actually going to look for specific ST elevation at the J points. So if you don't put in that it's a 60-year-old female, it just automatically goes to 40-year-old male, because like I said, that was the original demographic they went through with everybody. It's not going to read your 12 lead appropriately. So make sure you're putting in your gender and your age into your Zoll before you actually do your 12 lead, so it reads it appropriately. The other reason we're going to want to call is if it's a new or presumed new left bundle branch block. So if they have an absolutely known history of left bundle branch block, we can consider that. It's still recommended, just from the powers that be of shared health, that if they do have a left bundle branch block, we still call it in and let the cardiologist decide. Because what actually happens is the left bundle branch block can hide ST elevation. It can change how it reads it, so it can make things more complicated. And they would really prefer, and this is from St. Boniface, if it says left bundle branch block, or you suspect it based on what you've read on the 12 lead yourself, they want you to call it in. They just want to be sure, because it's hard to diagnose just with what we're doing if it's affecting their ST elevation or not. So the big question, can the patient arrive at the cath lab within the next 100 minutes? And again, that is from when we arrive at the house, not when they started having symptoms. If they've had chest pain for 3 days, that clock starts when we walk to the door. It doesn't matter. So when we arrive on scene. If the answer is yes, the paramedics will contact the physician only if they reasonably judge that a 100-minute window to the cath lab can be met by direct ground transport, or where possible by air intercept. So if it's going to be more than 100 minutes from the door to St. B, we're just going to go to the closest ED. Don't say, well, call the cardiologist, say, well, yeah, we're 150 minutes away, but if we got a helicopter, we can make it. The memo went out a little while ago stating that if it's more than 100 minutes when you arrive on scene, just go to your closest ED. Paramedics will transport at a safe vehicular speed, and any decision about road safety or transport remains the vehicle operator. So even if you could, on a good day, get to St. B within 100 minutes, but it's the middle of the winter time, roads are icy, you can't go faster than 30 kilometers, just go to the closest hospital. So we're going to contact the code Stemi physician and send a copy of the ECG. So paramedics will contact the medical, basically contact dispatch for the name of the code Stemi physician and contact that physician directly with the number provided to them by dispatch. If you're unable to get a hold of the physician, paramedics will contact the St. Boniface Hospital paging operator and request to speak to the on-call interventional cardiologist for a code 25 outside call. Good times, right? So where do we get the number for that? It's in that yellow box right at the top of the care map. So if you can't get, you've got the number for dispatch there. If you can't get a hold of cardiologist because there's not answering their phone, we can contact the St. Boniface Hospital paging operator. And again, that number is right at the top of the care map. So if you're unable to get a hold of anybody, you can call dispatch and speak to online medical support and ask for direction. So if you are going to transmit an ECG by text or mail or email, for us it would just be texting. The Personal Health Information Act requires you to obscure or cover the patient's identifying data. So when we do our 12 lead, before we actually take the analysis of your 12 lead, we put in the patient's sex, we put in the patient's age, but we don't need to put any of those names, anything like that into the machine. That helps reduce the chance of FIA breaches. But when you're taking a picture of your 12 lead to text to the cardiologist at their request, just make sure that you try to hide any identifier. So even if it comes to gender or age, you can try and cover that up. That way there's no way of really tracing it back to the patient. So you call the code Stemi physician, they ask you to send a picture. So you take a picture with your cell phone, you text it to the cardiologist, they take a look at it. Oh, I just got a question here. I don't know if everybody can see it, so I'm just going to read it. Says here, the care map says we exceed the 100-minute window, initiate transfer to close ED and call online medical support. Can you clarify online? Yeah, I will get into, basically the question asked is why do we need to call online medical support? I will get to that later. So that's a good question. We actually had a discussion about that at Shared Health, and I will bring that up later. Okay. All right, thanks. So if you text your picture of your 12 and or 15, don't forget to do a 15. Send those to the cath to the physician, and they say go to the cath lab. We start going to the cath lab. Only as directed by the physician, we administer Ticagrelor or Oxaparin. and we can request a helicopter at that point once they've been accepted by the cardiologist, because we don't want to send a helicopter before we text the cardiologist, because if they say, no, we just don't have space for these patients right now, we're overwhelmed, go to your closest ED, we don't need to start getting a helicopter flying. So make sure you talk to the physician first. If it's less than 100 minutes or you're like right at that 90-minute window, then you can request for a helicopter intercept, but you have to talk to the cardiac physician first. If the patient is stable upon arrival at St. Boniface Hospital, you can go to the cath lab if they're expecting you. Personally, I don't know what everybody else does, but I usually radio the ER anyways and let them know that we're going to be there in like 10-15 minutes so they can notify the cath lab so they can prepare for us being there. Also, it's nice if security knows, because then they can make sure the doors are open, especially if we go at night and everything's locked down. So if your patient becomes unstable, you may need to go to the ED first when you arrive at St. Boniface. If the patient deteriorates en route to Winnipeg, paramedics will redirect to the ED. So obviously, if your patient's having an MI and all of a sudden you're just whipping by Selkirk and your patient starts going like peri-arrest there, you can totally divert to your closest hospital and stabilize your patient. Just as a side note, in Winnipeg, the 3 places they want us to take emergent patients are St. Boniface, HSC, and the Grays. But if you happen to be going by Seven Oaks and your patient becomes extremely unstable and is going to code on you, you are permitted to stop in care centers for help. They don't really want us doing that, but we don't want a dead patient either. So you are permitted to do that if your patient is in extremis. So again, this is the medication profile in the Shared Health website. So ticagrelor. So again, we don't have the colored boxes. Your scope of work box will determine who can do this. So EMRs may not be able to give this medication, even if the code Stemi physician says so over the phone because their partner told them to, but PCP and up can. Again, only with direction from the physician. So with this indication, so known or suspected ST elevation, MI, when the patient is going directly to cath lab. So contraindications, patient may be a candidate for fibrinolysis with TNK. Active bleeding cannot be controlled. So when it comes to this medication, so with ticagrelor, it actually prevents platelet activation. So basically it prevents clotting. So if we have any type of internal bleed, we're obviously not going to give it. So this is one of those meds that if you were doing CPR before you got, and then you got ROSC, found your patient was having an MI, or you got direction to go to the cath lab, we probably won't be giving this medication, because with CPR, it's chest trauma. So there's a chance of bleeding. And of course, if they're allergic to it, we don't give it. This one's just a straight up 180 milligrams once, just oral dosing. So they don't chew it, they just swallow it. That's why I have bottles of water in the truck. So Oxaparin, again, this is only given on direction of the physician. So for this one, EMRs are not permitted to give this, but PCPs and up are. Originally, this used to be ICP, if everyone remembers last year, but St. Boniface Hospital actually requested that we expand scope so that way we can get this medication to the patients. So again, this can only be given under physician's order. So basically, Oxaparin is low molecular weight heparin. It basically binds and inactivates clotting factors. So indications, so Stemi with the patient going for PCI. Same thing as ticagrelor. So contraindications, like before, patient may be candidate for fibrinolysis with TNK. So the reason both these meds say not to give if they're going to consider TNK is that actually if you give it along with aspirin and other NSAIDs, it can actually increase bleeding. So that's why the physicians may hold off on giving it. Obviously, hypersensitivity to it, allergic to it. Again, patient not been on an anticoagulant and has taken it that day. So if they're on their daily aspirin, you gave them more aspirin, the physician may want to hold off because it then, based on patient presentation, it can increase chances of bleeding. So history of heparin-induced thrombocytopenia in the past 100 days. So that's actually what happens is heparin actually creates clots. It does reverse what you want it to do. So obviously if heparin is going to make more clots, we don't really want to give that to our patient. And obviously if they're bleeding out, we don't want to give anything that's going to make their bleeding worse. So when we give this medication, it's given intravenous or sub-Q. So if they're less than 75, it's 0.5 milligrams per kilogram IV or 1 milligram per kilogram subcutaneous. So a max of 100 milligrams. So we're going to give this, if we're going to give it subcutaneously, we're going to use those 1 cc vantage point syringes that we should have with our kits there. And the nice thing is that when you look at the max dose of 100 milligrams, the medication we carry, it's 100 milligrams per ml, and the vantage points are 1 cc. So if you're doing your math and you get more than 1 ml of medication, you need to check your math because that's over, or just give 100 because that's our max, is 1 cc of the medication subcutaneously. So if they're greater than 75, we're only going to give it subcutaneously because the chances of causing bleeding when you give it IV goes up exponentially. So we're going to give 0.75 milligrams per kilogram to a max of 75 milligrams subcutaneously. Ideally, IV is preferred, but with someone under 75. But if you can't get an IV because sometimes you just can't get IVs on your patients, then you can give subcutaneously. So we went through all the what to do if we get permission to go to the cath lab. The physician gives us orders. We had a couple boxes as we went down the care map where it says no. So can you arrive at the cath lab in the next 100 minutes? Nope. We've got to like at least 2 hours to the closest cath lab, so we can't make that. And does the code STEMI physician authorize transportation to the cath lab? What if they say no? We had one patient, actually, we were in the cath lab, we had a student, so we stayed there to let our student watch the procedure. And while we were there, the physician doing PCI actually got a phone call from another truck in Stonewall with another STEMI, and he just basically said, no, I'm already working on someone, go to your closest facility. So it's not always a patient situation, could just be a cath lab availability situation. So we're going to start going to closest ED. We're going to contact online medical support while en route. And if time allows, we're going to complete the TNK checklist. So with this here, when it comes to the question about contacting online medical support, I don't know if everybody saw the memo that went out yesterday. We were using STARS as our online medical support for quite some time. We are now doing it in-house. So we are only using shared health physicians as our online medical support. So with that, we have Dr. Anita Vermack, Rob Grierson, Aaron Weldon, and Tony Hurd. They are our online medical support. So with that, when we call them, they might actually give us direction to give medications for our STEMI. Because the other thing as well is that when I sent out the email with the new algorithm here, it had the in-hospital algorithm as well, so that we were familiar with it. So the idea is that sometimes the physicians in the ERs are not comfortable or familiar with what we're doing pre-hospitally. So by contacting online medical support, they may actually give us direction to give an Oxaparin or ticagrelor, and also talk with the physicians that they're receiving ED on what the next steps are as per the algorithms. So that's why they want us to call online medical support, because they can give us more direction of what to do pre-hospitally. And it might just be a simple case of them saying, you know what, just do what you're doing, go to the closest ED and stabilize, and then we'll set up a secondary transfer. So that's why they want us to call them. And they used to have OCS in this care map. That's taken out. It's just straight up call online medical support. The only two people we're going to be talking to for this care map is either a physician at St. Boniface Hospital or one of our online medical support physicians. So again, some patients beyond the 100-minute window may benefit from transport to ED capable of providing emergent fibrinolytic therapy, followed by prompt transfer to cath lab for subsequent PCI. Initiate transport to close ED and contact online medical physician while en route. If time allows, do your TNK checklist, which is the appendix at the end of the care map, while en route to ED. Unless otherwise advised, paramedics will remain with the patient pending a decision about emergent secondary interfacility transfer. So if you contact an online medical support, we've been given direction to go closest to ED. We go to the ED. If they're decided we're going to stabilize and transport out, we may not be cleared immediately. It's being requested that we stay with that patient with the understanding that we're going to stabilize and transport out to St. Boniface if possible. So just like we do with the stroke bypass, if we go to HSC and they're like, just hang on, we're going to check our patient first and see if they can stay or go. It'll be the same situation with our cardiac patients. We're not just going to put them on the hospital bed and take off right away. So we have our TNK checklist. I'm just going to do a quick review here. So again, if you have time, because obviously if our patient's having respiratory issues, things like that, we're going to be looking after the patient who may not have time to do a checklist, or if they're obtunded and can't answer questions properly, we may not be able to do this checklist either. Okay. But the big thing is that if any of the answers to the checklist are yes, we need to inform online medical support, because again, this is going to direct where our therapy goes. So if they have hypertension, if they have had traumatic or prolonged CPR, is there any active internal bleeding? Ischemic stroke within the last 3 months, intracranial bleed, patient significant head or facial trauma within the last 3 months. It says head or facial. I'm going to assume it's head or facial trauma. I'm just going with that. Has the patient had intracranial or intraspinal surgery or trauma within the last 2 months? Intracranial tumor, recent surgery. Is the patient pregnant within 1 week postpartum? Suspicion of aortic dissection, pericarditis. So allergy, TNK, or tenecteplase. So basically, long story short, we're going through this list here is these are all things we're worried about that can cause increased bleeding. If we give them medications, is it just as likely to kill our patient as save them? I have done one STEMI bypass where we went to the hospital and the doctor just straight up said the medications could either save them or kill them. So we're just not going to give anything. And we just ended up not giving any medications to our patient. They just dealt with it all in hospital because of their concerns based on the patient's history. So that's why we need to ask all these questions. Anybody have any questions at all?
Mike, you there?
Yeah, I'm here.
You recorded this. How can I get a copy of this?
What I do is I save it to the share drive and I'll send a link to everybody this afternoon.
Okay. Okay, good. There's a few that missed it I think could benefit.
Yeah, for sure. Yeah, I don't doubt there's people that are gonna miss it because I try to make it for 8:30 so that way I can get the both day crews in. But as we all know, transfers and calls happen. So yeah, I'll definitely make sure that it's linked for everybody.
No, that's good. There's lots of time when they can. There's lots of time during the 4 shifts they have that they can possibly get it done. But no problem. Thanks for recording it.
Yeah, no problem. Any other questions from anybody? So again, I'm just going to read this out because I don't know if everybody can see the chat. So the question is, so if the EKG says infarct, MI, left bundle branch block, you have to send it to the cardiologist. So with this, for the EKGs, I would recommend calling it in, yes. So if it says infarct, MI, left bundle branch blocks, like I said, any of the things that are in the word STEMI, in the acronym STEMI, I would call it in. Because like I said, we were having a while there where people are only calling if it specifically said STEMI or left bundle branch block. And basically cardiologists were like, why aren't you calling us for this? So I would recommend calling it in and let the cardiologist take a look at it. And the worst thing they can say is, you know what, no, go to close this ED. Fair enough, we did our due diligence and we did our patient care. So with this question here, with the new fentanyl protocol, are we able to use this for chest pain or is it only ACS or STEMI? So again, I'm just referring to the fentanyl for with ACS in regards to that. So it can be used for pain control as per the medication profile. So if you think it is appropriate for your patient to receive fentanyl for any other kind of pain, then yes, you can still use your intranasal fentanyl or just fentanyl for any kind of chest pain. So if it's like pleuritic chest pain, if it's causing a lot of distress to your patient and you do your due diligence by doing your vital signs and there's no contraindications, absolutely, you can give it for chest pain. It's not just for ACS. So the question came up here, we are getting our authorization to get medication solely from the M document. So it's a combination of the care maps and the M documents. So if you go down the care map and it says give pain control, you go to your M documents and based on your scope, you figure out, so that could be either Toradol for PCPs or intranasal fentanyl now for PCPs. So for pain control, it recommends giving pain control. You look at your care map. Okay, so the care map's guiding me to medication documents. You go to your medication documents, do it according to your scope, and that's when you decide to give your medications. So again, we're trying to get rid of the color boxes because I'm sure everybody's aware it's causing a lot of issues. It's like the medication says I can give this, but the care map's a different colored box. If you go down any care map and it states consider giving this medication or it suggests giving pain control, then you use that as your direction to the M documents. And the use of a care map along with a medication document authorizes you to give a medication. It's not just solely the M documents. Does that answer that question? That's why I kind of wanted to throw in the new way we're doing the care maps and the medication profiles. So that's why I wanted to bring it up in this as well. So thank you for asking. Oops. Okay. And there's another question. I'll just give it a second. It's all good. I like questions because if you've got questions, I'm sure other people do. So that's totally fine. Kind of ominous waiting for you to type out the question here. I feel like I'm going to get a paragraph. Anybody else have any other questions, comments, concerns? Okay. So the question is, so what is the reason behind the wording in A01 saying M documents do not provide authorization to administer meds? So the M document alone does not give you authorization to administer meds. So it has to be the use of a care map to guide you to the M document. So the two together give you the authorization. So it's not just the M document alone is what they're meaning by that. So like I said, if you reference your pain control care map and it says a patient presenting with ABC reasons, consider pain control, that directs you to your pain control medication documents as directed by a care map. So using the care map along with the M document, that gives you permission to use that medication. It's not just looking up the meds and doing it on your own. Awesome. No, that's a good question. I'm glad you're bringing that up because like I said, I'm sure there's other people. Are you going to send out an email with the update Stemi to contact Stemi doctor, MI elevation? I did send out a copy of the new care map out a couple times already. So the reason I'm doing this actual presentation right now is because not everything's in the care map. So that's why I wanted to do this online presentation to expand more on what was actually expected when we have a patient with suspected STEMI or MI.
Mike, you sent it out twice. We had this presentation. I mean, the staff all have it on their emails.
Yep.
On a personal note, to individually send it out again is a little overkill. But take it as you might.
Thank you. Yeah, like I said, I'm gonna save this to the share drive and I'll send everybody a link today. And as always, if there's any other questions or like 2 hours passes and you think about it, just let me know. So it says here, so no LMS can give us permission to administer Oxaparin and ticagrelor. So when it comes to online medical support, 3 out of 4 of our physicians are actually STEMI physicians. So it might actually happen. I know one person asked me about this where they did STEMI bypass and Dr. Hurd answered the phone. So 3 out of 4 of our ERS physicians that will be doing our online medical support are cardiac physicians that are permitted to give the medications. So when we contact online medical support, they can give us permission to give an Oxaparin to ticagrelor. So then it says, I mean, PCP only calling STEMI doctor for the word specific word STEMI. So yeah, like I said, if you are suspecting infarct, so again, if it doesn't have to just be that word STEMI, I know it says that in the care map, and that's why I'm doing this to expand on that, because if you suspect any kind of MI, if the SOL reads out suspected left myocardial infarct or left-sided infarct, inferior infarct, because that's a letter in STEMI, we should be contacting the physician. Again, like I said, if your patient's presenting with all symptoms of ACS, your ZOL is noticing that there's ST elevation in like the contiguous leads or suspecting an infarct, we can call it in. And like I said, the worst thing that can happen is we call it in, you're like, my patient's presenting with all the signs and symptoms of ACS. It's saying that they're infarcting. Should we come to you? They'll look at it and they might just say no. And that's fine, but at least we did our due diligence and we're trying. So yeah, so I'm hoping other people watch the presentation. That's why I brought it up here. Whenever I teach ACLS, I always bring that up. Even with BLS, I always bring that up too, depending on who I'm teaching. It's a good way to look at it. So I get what you're getting at there, yeah. Is there any other questions at all? I like the questions, they're good. They're very relevant and very expected, so it's all good. Oh, that's a good question. Okay, so the question came in, if ICPs, ACPs read the EKG and it says infarct, but they don't read it as such, do we still need to send it in? So again, that is at the discretion of the ICP, ACP. I'll be honest, I picked up a shift in Stonewall last month and I had a patient and my first 12 lead said STEMI, but when I actually physically looked at it, there was no ST elevation anywhere. So I double checked with my partner, and we both agreed that we weren't seeing ST elevation anywhere. So I actually did a secondary 12 lead, and it turned out it was just the patient had a lot of movement. She was very tremulous. That was affecting the reading. So the second one was just said normal sinus rhythm to confirm it. So again, if the ICP ACP decides that what they're seeing does not match what the monitor is saying, that's at their discretion. If there's ever a concern of what the machine's saying versus what you're seeing and you're not sure, call it in. But if they see it and they say, no, I disagree with this, that's at their discretion and how comfortable they are with reading their 12 leads. And the big thing is, of course, with everything, if your 12 lead does say STEMI and you disagree with it, document. That's the biggest thing. Like, document why you did not call when your 12 lead saying STEMI. And it might just be as simple as documenting Zoll states STEMI, no ST elevation seen on 12 lead and or 15 lead. So you can just do it that way as well. But as for PCP, I would strongly suggest that if you have, like I said, if it says STEMI or any parts of that, that you call the physician. If they're like, I don't see any ST elevation, awesome. But if there is something there, then they can deal with that. But for ICP, ACP, because we might be doing it on our own, then it's at our discretion whether we call or not. But just make sure you document why you made the decisions you did. Like, document the heck out of it, especially if you don't call the STEMI physician.
Mike, I'm going to sign off.
All right. Thanks a lot for sitting in. Any last questions there? So I scheduled this from 8:30 to 9:30, and we're pretty much right on time there. So if there's no further questions, going to end it there. And like I said, I'm recording this, so I'll send it to everybody, the link out this afternoon. And if there are any further questions at any point, totally feel free to call me or just send me an email, either way. All right, thank you for sitting in. It's been great.